I'm Dr. Priya Kadam. I'm the Director of Reproductive Genomics at MedGenome. It gives me great pleasure to introduce Dr. Neha Gupta, who will be presenting about this topic, RhD genotyping by NIPT. So most of the talk will be by her. After she finishes, I will have a few slides just to talk about the validation of this test at MedGenome and also what has been our experience in the past 1 year that we've been offering this test. So let me go introduce Dr. Neha Gupta in more detail. She's a consultant fetal medicine at Kailash Hospital, Noida, and she's received her diploma in fetal medicine from Barcelona. She also has a fellowship in fetal medicine from Delhi, and her special interests include fetal neurosonography and advanced fetal interventions. Previously, she has been associated with Chandigarh and also with IGMC Shimla. She's also the executive member of NOGS and a life member of FOXY and Society of Fetal Medicine. She has presented many papers in national and international conferences. So welcome, Dr. Neha. We look forward to listening to you.
Thank you, ma'am. So
I'll stop sharing.
So I'm just sharing my screen. Is it visible?
Yeah, Dr. Neha.
Okay, so I'm starting with the presentation. Well, thank you, ma'am, for such a nice introduction and a very good evening to all. I will be dealing with what is RH isoimmunization and now what is the role of NIPT for RhD genotyping in the management of RH isoimmunization. So I would be under following headings, I will be discussing the history, RH isoimmunization, how we can prevent our data, blood group systems and anti-globulin test, and how do we follow up these pregnancies, then about NIPT, RhD genotyping. So in 1939, the first mention about hemolytic disease of newborn was by Dr. Philip Levine and Dr. Rufus. And Dr. Karl Landsteiner and Dr. Wiener discovered Rh blood group, for which they received the Nobel also. And in 1941, Levine had published his theory on erythroblastosis fetalis. 1960s came the trial for Rh immunoglobulin under Dr. Pollock, and ultimately it was introduced in around 1970s in USA and England. So what is RH isoimmunization? So isoimmunization stands for development of immune antibodies in an individual by entry of an antigen of another individual belonging to same species. So that person lacks that antigen. So RH isoimmunization is development of IgG antibodies in a woman with the Rh negative blood group against that Rh antigen, most commonly the D antigen. And it is the most common cause of hemolytic disease of the fetus and the newborn. So the mother is Rh negative and the father is Rh positive. So there is a 60 to 70% chance that the baby in the womb would be Rh positive. So in that case, usually at the time of delivery, when the fetal blood enters the maternal circulation, and if no anti-D is given, so this positive RBCs are presented to the maternal immune system against which the mother's body develop antibodies. So the mother get isoimmunized and she has this antibody. Now, first pregnancy is unaffected. Now, in the second pregnancy, if the baby is again Rh positive, then these antibodies enter the circulation and leads to Rh disease. So as little as 0.1 ml of blood can lead to sensitization. So when these antibodies develop, they enter into the fetal circulation. These IgG antibodies, they crosses the placenta. They enter the fetal circulation, bind with positive RBCs and leads to destruction of the cells, leading to anemia. Ultimately, there is stimulation of extramedullary hematopoiesis, and you have hepatosplenomegaly, liver failure, ultimately leading to ascites, edema, and hypoxia. Now, this is the critical stage that we really don't want to enter. You can see the placentomegaly, the ascites, cardiomegaly, pericardial effusion, and severe subcutaneous edema, the severe hydropic stage. Now, since 50 years, we have prevention, that is anti-D available. And despite such an effective prevention, still cases of Rh isoimmunization are there. 50% of cases worldwide are not given anti-D prophylaxis. It could be due to ignorance, not following a proper protocol, unavailability, cost considerations, cold chain failures, or not checking for maternal fetal hemorrhage after the delivery. So FIGO came up with this guideline in 2020 where they prioritized according to the cost effectiveness. The high priority is after the delivery when anti-D should be given if the mother delivers an Rh positive newborn. The middle priority is the routine antenatal prophylaxis to be given to non-immunized mothers between 28 to 34 weeks. And this is really important because this has led down to a decrease in the immunization from 16% to 1.5%, and with antenatal prophylaxis, a further reduction by 0.3 to 0.5%. So anti-D is basically IgG antibody, which binds to fetal RBCs with D antigen and prevents stimulation of immune system. It could be polyclonal and monoclonal. And the 300 microgram that is used after delivery is enough to cover 30 ml of fetal blood. And the average T half is about 21 days. It's very important to calculate the dose of anti-D after the sensitizing events, and that is the amount of fetal maternal hemorrhage, which is detected by means of the KB test, that is the Kleihor-Betke test, which based on the thing that the hemoglobin F or the fetal RBCs hence are more resistant to acid than the adult RBCs, which carries hemoglobin A. So on a slide of the maternal blood, you see the number of fetal RBCs and calculate and multiplied by 100 divided by the total number of RBCs. Now, this percentage of fetal cells when multiplied by 50 and divided by 30 gives us the actual number of vials that are required. So usually more than 30 ml of fetal-maternal hemorrhage occurs in less than 1% of cases. We have had 22 isoimmunized cases over a period of from 2019 to 23, and majority of them are in the last 3 years. 20 of them received at least postnatal anti-D. Most common antibody was anti-D. 13 had an absolutely normal outcome. 8 had an anemia, and 1, we do not have any follow-up of that. And out of these anemia cases, 4 were under proper follow-up. 2 were given IUT starting at 27 weeks. 2, they were around 33 weeks of gestation, so they declined IUT and they were delivered. And all these 4 had a normal outcome. 4 was severe hydropic baby. 1 died on the day of evaluation. 1 received 2 IUT but died during the second one. 1 was hydropic at 20 weeks only, and 1 is ongoing. So let's just understand this with a case. So 33-year-old Gravida 3 para 2 with 1 living issue was referred to us at 27 weeks with ICT being positive. She was B negative and husband was AB positive. A little bit about the blood group systems. Now, there are 33 blood group systems that have been identified by this International Society of Blood Transfusion with 300 antigens, and 3 ABO system, our rhesus system, and KEL, the other 3 most important. Now, ABO system has 4 antigens, and ABO incompatibility is sort of protective against Rh isoimmunization, and this is seen in type O mothers, which carries type A or type B fetuses. Now, rhesus system has about 50 antigens, out of which 5, that is capital C, small c, capital D, capital E, and small e, are the most important ones. And it is the D antigen which contributes to most of the incompatibility, and presence of D is rhesus positive and absence of D is rhesus negative. Then there are other minor rare families like KEL, Lutheran, Duffy, MNS system. However, the antibodies, that is D, small c, capital K, small c plus small e, they are the most common ones that are involved in severe hemolytic reactions in the antenatal period. So a word about these antiglobulin tests. Now, direct Coombs test is that those RBCs, they are carrying the antigen, and these antigens, these antibodies, they have already combined forming with these antigens, that is forming an antigen-antibody complex. And when you add the Coombs reagent that contains anti-human antibodies, so there's clumping takes place. So this is direct Coombs test positive. In indirect Coombs test, we take the sera, which has antibodies. To this, we add RBCs that contains the antigen. So antigen antibody complex is formed. And then to this, we add the Coombs reagent, that is anti-human antibodies. They combine with these antibodies and agglutination takes place, and this is a positive result. Now, aim of antibody identification is that we need to identify these clinically significant antibodies which are involved in hemolytic disease in the fetus and the newborn, and to provide compatible blood products for mother and the fetus. Now, strength of antibodies can be determined by two ways. One is quantification. This requires special equipment where you get exact concentrations of anti-D and anti-C, but this is not available everywhere. The most common and that we use are the titration method, which can be done by tube, column, or solid phase. It is the column-based methods that is being most used now. It is much more sensitive than the tube method, and the reciprocal of the highest dilution that gives us a positive response is noted. Usually 1 in 16 is considered as the critical titer. So these are the column gel-based method which contains anti-human globulin cards, and here to which you add sera. If it gets settled down, it's negative. If the agglutination is seen in lower half, it is 1+. If it is throughout, it is 2+. If it is in upper half, it is 3+. And if it is just in the top, that is the 4+. So how are the mothers, Rh negative mothers are followed? Now, doing a blood group and the Rh status is the first test that we offer at booking. So if it is positive, nothing else needs to be done. If it is negative, then we determine husband blood group. If he's also positive, then antibody screen is done. So the mothers who are Rh negative and screen negative, the usual protocol that we follow is that the repeat ICT is then done at 28 weeks. If it is ICT positive, then you rule out passive immunization. ICT positive, then refer to a fetal medicine specialist. If it is negative, you give antenatal prophylaxis, determine the baby's blood group at birth, if positive, and then you give anti-D, and also need to do a maternal fetal hemorrhage test if it is available. For ICT positive, determine the history, rule out passive immunization, determine antibody and titer, and refer to fetal medicine specialist. So continuing with that case, now anti-D in this patient, anti-D and anti-C were diagnosed. The follow-up started at 18 weeks. In her previous obstetric history, her first child is all okay. She received postnatal anti-D and 1 blood transfusion. In second, there was no proper follow-up. She directly had a cesarean section at 38 weeks, and the baby died within few minutes. The baby was hydropic, most probably due to Rh isoimmunization, and she received 2 blood transfusion for anemia in that pregnancy. So her MCA PSV was normal. She was detected anemia at 27 weeks, and she was a candidate for intrauterine transfusion. So in this, we give an intramuscular injection of vecuronium. And after that, after the baby is immobilized, then we put a needle into the umbilical cord vein. So this is the needle tip, which is going into the, being introduced into the vein. That's my colleague, Dr. Pratima, was pointing out on the screen. This is the tip that you are seeing over here. Once it is inside, we check for the blood at the hub. If the blood is there, then the first sample is taken and it is sent for testing for the blood group for hemoglobin. This is the needle tip, and this is the blood being pushed, and it is going through the cord. So a proper follow-up. So in this patient, 3 transfusions were given intrauterine. The baby was delivered at 34 weeks, female, 2.3 kgs, and 1 exchange transfusion and IVIG given after birth. Discharge at day 5, the baby is doing absolutely fine. Now let's talk about NIPT, non-invasive testing for RhD genotyping. I'll discuss the form of these 2 cases. The first one was referred to us at 8 weeks with ICT positive. She had a first miscarriage, no anti-D given. Second pregnancy, 2.5 kgs baby weight, postnatal anti-D given, but they died at day 4. The history did not seem like that of an isoimmunized pregnancy. Another miscarriage, no anti-D given. So at 8 weeks, her titer was 1 in 64, anti-D antibody was identified, and we started her MC monitoring at 18 weeks, and she was counseled for doing NIPT RhD genotyping. The couple agreed for the same. So this NIPT was sent, and So the report came out to be as fetal RhD not detected in all the 3 exons. So the monitoring was stopped for this pregnancy. It was a big relief for this patient. And she came to us then after 20 weeks at 29 weeks, where IUGR was detected and the baby was delivered. The baby is at present doing well. The blood group was B negative. Another case that was again at 8 weeks with ICT positive. First miscarriage, anti-T given. Second normal delivery, postnatal anti-T given. She was detected as ICT positive in the subsequent pregnancies where she underwent termination. So when we determined her titer, again 1 in 64, anti-D identified, and her screen and her monitoring was started at 18 weeks. She was also offered NIPT. Her test came out to be RhD detected. And for her, the monitoring continued every 2 weeks. And at present, she is 30 weeks and is doing fine. So what are the indications? Now, indications that have been mentioned are to do RhD genotyping in every Rh negative patient to guide antenatal prophylaxis. So as to have a targeted approach to this thing. In alloimmunized pregnancies, monitoring can be stopped in mothers if who are carrying who have anti-D antibody and are carrying D negative fetuses. And those with recurrent bleeding, RhD genotyping can be done so that repeat tests for fetal-maternal hemorrhage and anti-D administration can be avoided. Now, this is the protocol. The first one we've already discussed. This is the protocol that is from Australia, where the determination of at 11 weeks, NIPT for RhD status is done. If it is negative, no antenatal prophylaxis is done. If it is positive or the test is inconclusive or uncertain, then the repeat test ICT is done at 28 weeks. And if it is negative, antenatal anti-D is done. If it is positive, you refer to a fetal medicine specialist. Subsequently, you determine at birth, and if positive, anti-D is given. Now, this is target approach of giving routine antenatal prophylaxis. And by this approach, according to them, that 40% of the women who will be carrying an Rh negative fetus will not have this anti-D. So to do it in isoimmunized pregnancies, there's our RCG protocol and also this Australian protocol, where they say, in fact, every guideline is now endorsing it, that if you have the facility and if it is isoimmunized pregnancy, do an NIPT. If it is negative, you can stop the monitoring. But if it comes out to be positive, then you refer it to a fetal medicine unit. Now, Rh gene is present on chromosome 1. It has 2 genes, that is RhD gene and RhC gene. So the basis of this test is that if RhD gene is absent, the patient will be as RhD negative. So this is the basis of the first generation NIPT RhD genotyping. But exception to these are the variants where the patients may have pseudogenes or the hybrid genes, and these could be source of false positives. What is the timing? The guidelines that say after 16 weeks, but exactly we have to follow what the lab specific guidance is. And it can be done after 10 weeks. False negative is usually less than 0.1%. So when to do is actually you need to follow the lab specific guidelines. So methodology is that cell-free DNA is extracted from the maternal plasma and real-time PCR for RhD sequences is done. Usually single exon, but multiple exons of RhD should be sequenced because that reduces the false positive. It can be done for D antigen, small c, capital C, and capital E, and as well as for KEL antigen. Various studies have shown that the overall sensitivity is about 99% with very few false negatives. Now, what can be the implications of false positive or a false negative? If it is a false positive, that means the fetus is diagnosed as D positive, but is actually D negative. So if the pregnancy is not immunized, an antenatal prophylaxis will be given. And if it is unimmunized, unnecessary follow-up, adding to the anxiety of the couple. Usually false positives are seen in those where the gene is not translated or expressed like pseudogenes or hybrid genes, or where it is weakly expressed like weak D or partial D types. It's the false negative that we are more worried about, because the fetus is diagnosed as D negative, but is actually D positive. Because if the patient is not immunized, then routine prophylaxis will not be given, increases her chances of getting immunized. And if she is immunized, then follow-up will not be done. Reasons usually are very low levels of cell-free DNA and doing the test at early gestational ages. So this was a very nice flowchart that clearly outlined that what is the risk of adverse effect in those females who are undergoing routine RhD genotyping. So if you have about 68,000 D negative pregnancies and all of them undergo genotyping for fetal RhDs by cell-free DNA, and if we consider the false negative rate as 0.2%, so 137 pregnancies are at risk. After birth of a positive baby, all of them will be given postpartum prophylaxis. Now, 1% of them will be isoimmunized, that is 1.37. Now, in the subsequent pregnancy, 0.6 women will be at risk, that is 1.37 for chances of subsequent pregnancy and the risk of the fetus being D positive. So 0.6 women will be at risk. And the risk of fetal death or significant adverse outcome is around 2%. So the chances of having a significant adverse outcome is 1 in 5 million of D negative pregnancies that undergo fetal RhD genotyping. So has the time really come for implementing it for all Rh negative pregnancies? There has been a lot of cost-benefit analysis that have been going on. This is from the Canada, where they said, yes, if it is implemented, then they would be saving about 4,000 doses of anti-D over a period of 1 year period. Then similarly, the study in Canada in 2022, they said that non-invasive genotyping, fetal RhD genotyping, saves resources and represents a good value for the management of isoimmunized pregnancies. And if the cost of test is substantially decreased, then it can become a viable option for non-immunized pregnancies. Just a brief outline, this is what we have found out. In isoimmunized pregnancy, if you take up the cost of ICT, antibody identification titers, monitoring by ultrasound, roughly an average cost turns out to be 30,000. You add to this transportation charges, anxiety of the couple. In comparison to doing the test is about 40,000. Similarly, in non-isoimmunized pregnancy, the cost of doing ICT, blood grouping, and anti-D prophylaxis somewhere around 11,000 in comparison to the cost of doing this NIPT RhD genotyping. So what I think is that it's a very good test that should be offered to isoimmunized pregnancy, because that helps us in guiding the management. A word about MedGenome RhD track. So in this, cell-free DNA isolation is done, amplification by real-time PCR for 3 exons, that is 5, 7, and 10. Now these amplicons are then detected with probes which are labeled with fluorescent dyes, and then this signals are picked up by the optical detection unit of the real-time PCR. It can be done after 11 weeks. If the baby is Rh negative, turns out to be RhD negative, and the gestational age is less than 20 weeks, then need to be repeated after 20 weeks. The specificity is around 100%, sensitivity is around 98.8%. It's not valid for vanishing twins or multiple pregnancies. Serologically, Rh negative mother or fetus may test positive for RhD genotyping. These are basically because of the D variants. False negatives in RhD positive fetus can be due to rare clinical subtypes. So with this, I conclude with saying that antibody screen is to be done in every Rh negative pregnancies. Those which are screen negative, prevention is really effective, and both antenatal and postnatal prophylaxis to be given. Test for fetal-maternal hemorrhage to be done after 20 weeks after the sensitizing event, but I really do not know where it can be done. And antibodies, if antibody screen positive, determine the type of antibody and titer, and ensure proper follow-up of such pregnancies, because with proper follow-up, the outcomes are really good. So refer to fetal medicine specialist early. NIPT RhD genotyping is a game changer in the management, because if it comes out to be negative, it allays down a lot of anxiety for that couple, and at least it can be done for isoimmunized pregnancy. And proper counseling of the patient is the key. So with this, I conclude. Thank you. And this is my department, Kailash Hospital. So
Thank you, Dr. Neha. Excellent presentation and very, very comprehensive with the existing situation, and also the cost benefit analysis is something which I found very interesting because we don't have it in the Indian setup. So let me just continue and then we'll take questions in the end.
Sure, ma'am. Yeah.
So Dr. Neha has actually covered most of the factors. I'll just tell you all what has been our experience. I mean, all these factors have been covered. Only thing is, when the cell-free DNA was identified in 1997, right 1 year after that, that is in 1998, it was already identified that RhD genotype of the fetus can be identified through cell-free DNA testing. And the application of NIPT actually has been, first being demonstrated in this, for testing the Rh negative women. And there are several countries which have done these analysis or the cost benefit analysis, and some of the countries have used it as a standard protocol now. Dr. Neha also showed this. Let me just do it. Yeah. Has also shown the various meta-analyses or studies which have used different number of exons, right? So anywhere from 1 exon to about 3 exons to identify. And as she said, it is certainly more beneficial to use 3 exons, especially exon 5, because you can identify the psi variant, which is the pseudogene. So like you can see here, the sensitivity, specificity, negative predictive value, and positive predictive value in all these studies is over 98 and 99%. So as such, the utility of this test has been established. So I just want to refer to 2 Indian studies which have also demonstrated the usefulness. This was in 2019, again from PGI Chandigarh. And what they have identified, they have used only 1 exon actually in this. And the sensitivity again was about 99% and specificity about 92%. There were about 130 samples or so, or 122 samples, total of 135. The other group which has been working extensively on this and also has a very detailed account in 2016, and this paper in 2022, which actually gives a very nice account of all the details of how this test can be developed. And they initially used just 2 exons and then moved on to the others for tests which are conclusive. That is, in about, I think, 94% of the cases, they had a definite result. There, the accuracy is 100%. But the other 6% were inconclusive, of which they were able to evaluate further. So with that, they would have a revised sensitivity and specificity. So just stepping back a little bit, going into what is the basis of this test, we know that all of us have cell-free DNA in our body. All men and women, there is some amount of DNA which is outside the cells. And when a woman is pregnant, the DNA of the mother as well as the fetus is seen circulating as early as 4 to 5 weeks of pregnancy. So other than DNA, there are other forms of genetic material from the mother, from the fetus, which goes into the maternal circulation. It could be maternal cell, it could be RNA. But what we have used right now is the DNA. Now, there are certain factors about this cell-free DNA which we should be aware of. It has greater implications for aneuploidy testing and microdeletions or any other kind of testing. But for this, one factor to remember is the cell-free DNA is both of the mother and the fetus, and the fetal fraction is about 5 to 25%, and it clears rapidly after circulation, after the baby is delivered. So that means to say that the selfie DNA which you're taking actually pertains to the current pregnancy. So that's why when there is a vanishing twin, there could be a confounding result, because we have noticed that the selfie DNA from vanishing twin can be detected much, quite a long time after the demise, the fetal demise as well. So this test, this has been one of my pet projects. We have been working on non-invasive prenatal testing for over 8 years now, offered aneuploidy testing, microdeletion testing for a while. And then we kind of evaluated the different number of exons that we could use to give, because we know that in the world, the population, different population have evolved differently. And the number of Rh negative and Rh positive people are different, the percentages. And in India, it was previously considered to be about 1 to 3%. The paper by Pacharev, which I showed, one of the Indian studies, has shown that, the estimate that they have given is Rh negative women are about 5%. But I'll show you data later, which is pretty interesting actually. So the clinical validation actually had 3 steps. So this is for any lab standardized test. We would go through several phases of validation. So first is, of course, to test, to optimize the test, to familiarize with the QCs, and then to make sure that it is reproducible and repeatable. And third thing is the clinical evaluation. For this, I'd like to thank Dr. Mandakini Pradhan, because she had been she provided the samples and also useful discussions when we were developing this test. And we identified 100% specificity and sensitivity for the ultimate protocol, which we have decided to use. So the process, as Dr. Neha has already said, we collect about minimum of 7 ml of blood in a strect tube. Gestation age, here we put 10 weeks, so it's about 11 weeks. We do get samples before 11 weeks, it will be 10 weeks some days. We amplify 3 exons, 5, 7, and 10. It is the CT value which determines the presence or absence of RhD gene. The figure which you can see on the top right actually shows a Rh positive sample. So this is a graph which shows the CT value. That is the cycle of PCR where the amplification happens. So you see the three graphs there. So that is an Rh positive sample, and the one below here is a Rh negative sample. There is also always to make sure that the test is working and there is selfie DNA there will be a internal control as well. So let's look at the demographic data of the samples that we have worked on over the past 1 year. What we have seen is the average maternal age is about 30 years, average gestational age is 16 weeks, and patients with isoimmunization is about 38%. And also, what we found is the most common gestation age at which people send samples. So about 50% of pregnancies are tested before 16 weeks of gestation, and after that it reduces. But we have had samples even as late as 34 weeks of gestation. The other thing is, even in the first pregnancy, we have about 3.5% of samples which come in the first pregnancy itself. And after that, for about 20-25% for Gravida 2, Gravida 3, Gravida 4. And this is what was interesting to us. The RhD gene is detected in about 87% of the cases. In about 10%, of our samples are actually Rh negative. Now, this we have also looked at the data collected from other regular testing of Rh genotyping as well. Regular Rh testing, which is about 11%. And we have found about 2.4% of the cases which are inconclusive. The reason for inconclusive result has also been discussed by Dr. Neha. So what are the types of results you can expect once a sample is sent for RhD genotyping? It will be Rh positive. So based on the protocol, you would have to continue the follow-up. RH negative, of course, this is a result which is a sort of a relief for the parents and the clinician, because then, as the protocol suggests, the monitoring can be stopped, and then the baby can be tested at birth. And the other thing is inconclusive results. Inconclusive results are mostly because of the variants which are present in the mother. So we must remember, I'll go a little further into that what we are testing in cell-free DNA is actually what is in the genome, not the expression of the protein. The expression of the protein is done by our regular tests. So there can be a woman who does not express the protein, but she would have a variant of the RhD gene, and therefore there would be some amount of it would show up in the test result, because the cell-free DNA is supposed to represent the entire genome of the fetus as well. So if the RhD pseudogene is detected, also it is treated as RhD positive. So this has also been shown by Dr. Neha. So if the most of the cases when it is RhD positive, it will have this particular gene, RhD gene. We know that this complex contains two genes, RhD and the RhCE. RhD gene will code for the RhD protein, and CE is the CE component. So this RhD gene is between these two boxes, which are called rhesus boxes. And because of a loss or deletion, most of the Rh negative individuals do not have this gene in this place. Okay, so that is why it is not present in the genome, and it will not show the expression on the RBCs. But we know that these two genes have about 93% sequence identity and 96%. They're highly homologous. So they do interfere with some of the results. I will not go into the details of this. We just know that the RhD gene has about 10 exons, and these are all the variants which are present. So what is important is the expression of the protein. So here you see that RhD gene is this white box. When there is no RhD gene, it is because this entire gene will be deleted, and then it forms a hybrid rhesus box, which is this and this. And then the other common variant is the RhD pseudogene, which interferes with the results sometimes. In our case, we have seen as such inconclusive results are about 2.5%. And here, this is because of a duplication here, which causes a frame shift, and then a substitution, which causes a termination codon. And therefore, this will not express on the RBCs. And then there is another hybrid. So it is the Bachure's paper that is from the National the NIIH. What they have shown that about 68% of the Indian population will have the gene deleted. The rest would probably have either of these. And here, this is a hybrid between the RhD gene, which is what you see here, and this gray box is actually a hybrid from the RhCE, which has a few sequence variants. So now we know that if the father is Rh positive and mother is Rh negative, all children will be Rh positive. So this is already known, because it behaves as an autosomal dominant trait. Then if the father is heterozygous, then 50% of the children are likely to be Rh negative and 50% Rh positive. So for this test, we can accept samples from as early as 11 weeks. It is 10 ml of fresh blood from strep tube, maternal peripheral blood. It can also be combined with aneuploidy testing if desired. So I'd just like to conclude here. RhD detection by NIPT is highly sensitive and specific, and it's the only non-invasive method to know the fetal blood group, the Rh blood group. And the Rh negative rate that we have seen here is higher than what was expected. Of course, it can guide targeted prophylaxis and management of pregnancy. Cost effectiveness has been demonstrated by Dr. Neha as well in our setting, and also several other papers. And and you can get the information as early as 11 weeks of pregnancy. And of course, it avoids unnecessary treatment of pregnant women who carry RhD negative fetuses. So I'd like to stop here. And Dhiraj, if there are questions, we can take them.
Thank you so much, ma'am. Thank you, Dr. Neha, and thank you, Dr. Priya, for this wonderful session. And I'll just take few questions. I think we have one or two people who raised their hand. We have Dr. Pratima. So, Dr. Pratima, you can ask your question.
Hi, Dr. Priya. Can you hear me?
Yes, yes, very well. Good evening.
Hello. So it was an excellent presentation by both you and Dr. Neha. So I have a query that if we send you a sample at around 10 weeks, 11 weeks, and you say it as RhD negative, the fetus is RhD negative, do you recommend repeating the test again at 20 weeks?
Yes. Right now in our protocol, it is that way. The only concern in this usually is whether the cell-free DNA, enough cell-free DNA is present or not. So actually, very, very small amounts of cell-free DNA can help in identifying the gene if it is Rh positive. Many times these samples are sent along with the testing for aneuploidy. So if we actually have the aneuploidy testing, we already have the fetal fraction. So in that
Yes.
case, we are relatively comfortable with giving a Rh negative result. Right now, the protocol recommends that, but I think as we, continue testing more and more samples, we will probably relax that a bit, because what we have seen of the 10% of Rh negative samples, we got some of those samples actually came very close to 20 weeks, where it was not actually recommended. And then some of the samples, one was pretty early, so we recommended a repeat sample, and that again was Rh negative. So as such, the sensitivity is there, but right now we are just being a little extra careful.
Okay. So would you prefer that we actually send you samples at around 16 weeks rather than just doing it as early as 11?
Yes.
Would
Yes.
sending it a little later, because anyways we are not going to monitor the pregnancy for from 18 weeks onwards.
Yes.
So it will be preferable if we send it a little later.
Yes. That should work as well. Yeah.
Okay. Thank you.
Thank you, Dr. Pratima. So, if anyone else wants to ask their question, they can raise their hand. I'll just unmute them.
Yeah, so I think there is one question in the question and answer session
Yeah,
by
ma'am.
Mahajan. So we can ask him the amount of cell-free DNA required for the test. I think it is 0.1 nanogram per ml. So it's a very small quantity. We do measure the amount of cell-free DNA, the total amount of cell-free DNA. So, the amounts definitely are much more than that. And DNA quality is checked by the presence of internal controls, and also the working of the assay. I hope that answers your question, Ankit.
Thank you so much, ma'am. So, if anyone else have any questions, we have Dr. Neha and Dr. Priya Kadam, so they would be happy to answer. I think, ma'am, we don't have any queries.
Oh, okay.
So,
So,
yeah, ma'am.
I think we would like to conclude, and thank you so much, Dr. Neha. It was a very nice presentation and very comprehensive.
Thank you, ma'am. Thank you.
Thank you all attendees for joining in, and Dr. Pratima as well for your question.
Okay, so thanks all once again, and thank you, Dr. Neha and Dr. Priya, for this wonderful session. So I hope, like all the people who have attended, they got benefited with your talk. And down the line, in coming days, we'll have more sessions like this. And thank you so much, ma'am. Thank you.
Thank you, Dheeraj, for
Yeah.
organizing it, and thank you, Dr. Neha.